Bismillah ar-Rahman ar-Rahim. First of all, I would like to thank the organizing committee, Professor Ghada Abdulrahman al-Khatib, Professor Ghada al-Saghir, for inviting me to participate in this prestigious conference. My talk is NAFLD and Thyroid, the mutual relationship. My agenda is epidemiological evidence, immunopathogenesis and liver autophagy, hormone replacing therapy in NAFLD and NASH, the newest therapeutic agents, the Thyromimetics, in the treatment of NAFLD and NASH. NAFLD and NASH starts by steatosis and then progresses to steatohepatitis and then cirrhosis, and which may progress to development of hepatocellular carcinoma. Hepatic steatosis is defined by liver fat accumulation over 5% of hepatocytes with the lack of other secondary causes, or by over 5.6 of proton density fat detected by MRI spectroscopy. This figure presents the steatosis of more than 5% of hepatic cells loaded with fat droplets, and when hepatocyte ballooning is present and when associated with lobular inflammation, then steatohepatitis is diagnosed, and when fibrosis sets in, then cirrhosis is diagnosed, and all will progress to possibly development of hepatocellular carcinoma. Hypothyroidism-induced NAFLD, HIN. Hypothyroidism-induced NAFLD was acknowledged recently as a distinct disease entity. Hypothyroidism may probably be the best example of NAFLD secondary to an endocrine disorder. Thyroid dysfunction in NAFLD. In euthyroid overweight and obese children, researchers found a prevalence of NAFLD of almost 30%. At the same time, NAFLD individuals had significantly higher TSH levels than non-steatotic subjects, while T3 and T4 were in the normal range. Hypothyroidism was more frequent among patients with NAFLD. Bagadla et al. Found that hypothyroidism was more frequent among patients with NAFLD, being 21% versus 9.5% when compared to controls. And NASH was much higher in hypothyroidism was much higher also in NASH compared to normal controls. This figure represents the frequency of hypothyroidism in NAFLD compared to control. There is a much higher significant rise in frequency of hypothyroidism in NAFLD compared to normal controls. While this figure presents that the frequency of hypothyroidism in NASH was even more frequent than in steatosis, simple steatosis. At the same time, subjects with hypothyroidism were 2.1 times more likely to have NAFLD and 3.8 times more likely to have NASH. Thyroid hormones and immunopathogenesis with hypothyroidism, with raised TSH level and normal or low T4 and T3, they signal through their signaling inside the liver or inside the hepatocyte by reducing the adenosine monophosphate kinase and stimulating or activating the THRB, the steroid regulatory element binding protein 1, and decreasing the hepatic lipase activity and decreasing the hepatic triglyceride clearance. This together with mitochondrial affecting the mitochondria through autophagy and increasing oxidative stress, increasing TNF-alpha and inflammatory cytokines, and increasing leptin together with decreased adiponectin. All these factors together with adipose tissue sharing by releasing free fatty acids in consequence to insulin resistance, all these factors lead to triglyceride accumulation inside the hepatic cell with the production of non-alcoholic fatty liver disease or NAFLD. There is a linear association between TSH level and increased risk of NAFLD or NASH. Tanasi et al. Found this association. Additionally, free T3, free T4 ratio with insulin resistance, weight circumference, and hypertriglyceridemia was found to be independent risk factors for NAFLD in hypothyroid or euthyroid patients. Furthermore, Lee et al. Found that this entity of subclinical hypothyroidism was related to an increased risk of NAFLD in males, but not in females. However, Kim et al. In 2018 conducted an elegant study where they studied patients with biopsy-proven NAFLD. 282 were assigned to strict normal thyroid function. 59 patients were assigned with low thyroid function and subclinical hypothyroidism. 84 patients were assigned as low normal thyroid function. These will be evident in the coming slide, where the strict normal thyroid function was diagnosed by TSH at the range from 0.4 to 2.5. The subclinical hypothyroidism was diagnosed by TSH more than 4.5 with normal T3 and T4. The low normal thyroid function were diagnosed by TSH from 2.5 to 4.5 with normal T3 and T4. The results indicated that NASH and advanced fibrosis were found in higher percentage of subjects with low thyroid function versus strict normal thyroid function. Added to this, higher proportion of patients with subclinical hypothyroidism had NASH and associated fibrosis more than the low normal thyroid function. This figure presents the frequency of NASH and advanced fibrosis being more significant, raised in patients with low normal thyroid function than in patients with strict normal thyroid function. This figure furthermore presents that the frequency of NASH and advanced fibrosis was more significantly higher in patients with subclinical hypothyroidism more than the patients with low normal thyroid function. TSH promotes the triglyceride hepatocyte uptake and endorses liver steatosis through binding to TSH receptor, which sets the hepatic THRB1 activity and decreased AMPK function at the end, leading to raised lipogenesis. Now we will shift to another topic, that is the thyroid hormone receptors. We have the thyroid hormone receptor alpha-1, which is found in brain, cardiac, and skeletal muscle tissues. the thyroid hormone receptor beta 1, which is present in brain, the liver, and the kidney, and thyroid hormone beta 2 receptors, which is found in hypothalamus, retina, and pituitary. Regarding the thyroid hormone signaling pathways, the thyroid hormone, to exert its function, it enters into the nucleus of the cell, the hepatocyte, and then there are 4 types of signaling of thyroid hormone to exert its function in the hepatocyte. Type 1 and type 2 have to be linked to the DNA in the hepatocyte, either linked in type 1 to RXR retinoid receptor or to a protein receptor in type 2. While type 3 and type 4 are non-genomic, exert their function by non-genomic signaling through other mechanisms. There is reduced expression of thyroid hormone receptor beta in human non-alcoholic steatohepatitis. Although the systemic levels of thyroid hormones may stay within the normal range, yet the intracellular signaling machinery consisting of transporters, deionases, and receptors are affected in patients with NAFLD. This is very important knowledge. That is to say, the thyroid hormones may be normal. However, the transcription of the thyroid hormones inside the hepatic cell may be disordered in patients with NAFLD. Interestingly, in a study that analyzed the gene expression in 85 liver biopsies from patients with different stages of NASH, Cruz et al. Found that thyroid hormone receptor beta mRNA expression was inversely correlated with NASH histologic activity and declined further with age, indicating a possible tissue-specific resistance to circulating thyroid hormone. Not only the transcription of thyroid hormones inside the hepatic cell is disordered, but also there may be, or there is still an entity of thyroid hormone resistance inside the thyroid cell, which will be reflected in hypothyroidism, which will be reflected in the machinery of signaling of thyroid hormone inside the hepatic cell. This figure presents the negative correlation between NASH score and thyroid hormone beta receptor. And this figure presents the negative correlation between thyroid hormone receptor beta 1 and age. Now, we will shift to another entity, which is hepatic autophagy. Autophagy was originally characterized as a catabolic process targeting cellular constituents, including unfolded proteins, damaged organelles, and intracellular pathogens, which drives these components to lysosomes for degradation. Autophagy is classified into macroautophagy, chaperone-mediated autophagy, and microautophagy, and this figure presents the various types of autophagy, bringing various molecules and organelles to the lysosomes for degradation. It's obvious here also that the mitochondria is one of the organelles that when autophagy affects it, it is called mitophagy and goes to the lysosome for degradation. Now, lipophagy, autophagy-induced degradation of hepatic lipid droplets is termed lipophagy. Since lipophagy involves the selective degradation of hepatic lipid droplets, autophagy in liver could serve as a preventive mechanism against NAFLD. Hepatic autophagy regulates lipid metabolism through elimination of triglyceride accumulation in liver and prevents the development of steatosis. So enhancement of autophagic process or activity using pharmaceutical agents such as rapamycin and carbamazepine has been shown to retard the liver steatosis. In contrast, the lipotoxic effect of oxidative stress and the insulin resistance inhibit activation of autophagy. Moreover, pharmacological inhibition of autophagy leads to dramatic increase in the cellular triglyceride level. So we come to the conclusion that dysregulation of the autophagic process is reported to cause an imbalance in energy metabolism in the liver and consequently trigger disease. Kai et al. Results in 2016 indicates that thyroid hormone and thyroid hormone receptor signaling axis coordinates both transcriptional and post-translational regulation of hepatic autophagy. So the finding is that thyroid hormones and thyroid hormone receptors via autophagy stimulation prevent hepatic damage, prevent hepatic steatosis, and prevent hepatocarcinosis, supports their therapeutic potential in clinical application. Autophagy and mitochondria. Similar to the lipid droplets, the mitochondria are affected also by autophagy. The balance of mitochondrial biogenesis and mitophagy is a precisely regulated process that influences cellular homeostasis. Activation of hepatic mitophagy, that is the autophagy of the mitochondria, is reported to eliminate lipid content and oxidative stress. So this regulation of mitophagy is implicated in the progression of NAFLD. Thyroid hormones is considered an inducer of mitochondrial activity and oxidative stress. However, thyroid hormones also induces mitophagy to prevent accumulation of damaged mitochondria and prevents hepatic injury by excessive reactive oxygen species production, as we have discussed in the figure where the disorganized mitochondria, what is called the mitophagy, goes to the lysosome to be degraded. Now we shift to the important subjects of thyromimetics and NAFLD and NASH. The target of management of NAFLD and NASH is NASH resolution with no worsening of liver fibrosis and or fibrosis improvement more than one stage with no worsening of hepatitis. This is a milestone in the development of thyroid hormone mimetics, thyromimetic drugs, and liver disease. GC1 was the first synthetic thyroid hormone receptor beta agonist that could be used as scaffold compound for developing other thyroid hormones derivatives. Martagon et al. Investigated the ability of thyroid hormone agonists GC1 and KB2115 to reduce hepatic steatosis in mice. Both compounds markedly reduced the hepatic triglyceride level and ameliorated hepatic steatosis. However, with lower doses of GC1, there was impairment of glycemic control and increased insulin resistance, while a higher dose of GC1 resulted in substantially improved glucose tolerance and insulin sensitivity. All doses being equally effective at reducing the hepatic triglyceride level and steatosis. This figure presents the improvement of hepatic steatosis with GC1 histologically. However, this figure presents the impairment of glucose and increase in hormone resistance with low doses of GC1. However, with higher doses of GC1, there is improvement in glucose and improvement on hormone resistance or insulin sensitivity, together with reduction of the hepatic significant marked reduction of the hepatic steatosis. So GC1 proved to be effective in higher doses to improve insulin resistance and hepatic steatosis. Arion et al. Developed another drug, the MB07811, which was found in high-fat diet exposed or diabetic fatty animals. 2 weeks of the drug significantly reduced both hepatic and plasma triglyceride level with no other side effects of thyroid hormones. This figure presents in the red lines, in the upper two, in the red lines, presents the improvement in liver triglyceride and in serum cholesterol and triglyceride level with GC1 administration, with the drug and MB 0711 administration. Another two beta receptor agonists, the MGL3196, VK2809, has been developed, and results from phase 2 trials showed preventive effects on NAFLD, accompanied by a decrease in serum levels of low-density lipoprotein cholesterol and triglycerides, as well as hepatic lipids, with none of the side effects of the thyroid hormone axis. And lastly, the receptor developed in the treatment in NAFLD. Harrison et al. Randomized patient with biopsy-proven NASH to receptor versus placebo, and at 12 weeks there was a significant reduction of NASH activity in the receptor group compared to placebo, and at 36 weeks there was also a significant reduction of the NASH activity with receptor, the beta receptor agonist, compared to the placebo. This figure presents the effect of receptor on NASH at 12 weeks, and at 36 weeks, there is around 36% reduction of NASH activity with receptor, and at 12 weeks, and about 39% reduction of NASH activity with receptor compared to about 9 to 10% for the placebo. And take-home message: firstly, thyroid hormone and thyroid hormone beta agonist helps clearance of hepatic triglycerides through the autophagic process. Secondly, thyromimetics proved to be 10 times more effective in reducing NAFLD and NASH activity than other farnesenoid FXR and PAPR gamma agonist. Thyromimetics seems to be the future drug in management of NAFLD and NASH and hepatocarcinosis or hepatocarcinogenesis. And thank you.